Hello, welcome to Healthy Aging Perspectives. I'm Marianne Johnson. I'm from the University of Georgia's Institute of Gerontology and Department of Foods and Nutrition. First, what is health? It is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. What is healthy aging? It's living a long time, or our lifespan, which is the result of interactions between genes and the environment in which we live. And living in good health. When our living conditions improve, our mortality decreases, and evolutionary pressures for early survival and reproduction relax, and further resources can be invested in body maintenance and repair, which increases both average life expectancy and maximum lifespan. To be more specific, healthy aging involves reductions in mortality and morbidity in terms of chronic conditions, mobility limitations, ADL limitations, sensory changes, and our cognition. At the population level, we can measure life expectancy and healthy life expectancy. Healthy life expectancy subtracts years lived in less than full health due to disease or injury. On the left of this slide, you'll see age, and across the bottom, you'll see two bars. The blue bar is life expectancy at birth, but the yellow bar is healthy life expectancy. And you can see for most countries, there's about a 10-year difference. So overall in the world, in Africa and Southeast Asia, Eastern Mediterranean, Europe, Western Pacific, and in the Americas. So for example, in the Americas, life expectancy at birth averages 77, but healthy life expectancy is only 67. So 10-year difference. In the United States, we've looked at healthy life expectancy at age 65. The dark blue states are those that have 15 more years on average, or that's living till 80. But the white bars are under 13 years, so an over 2-year difference in those states. And in fact, some of the states marked in white only have an 11-year healthy life expectancy after age 65. These data are not corrected for race, ethnicity, or income, so they starkly show the health disparities that we see across the United States, with the Southeast having the worst problems or the lowest healthy life expectancy. Well, where do older people live? This slide shows in the darkest color living in a traditional community, with 65 and older all the way on the left, and 85 and over on your right. And not surprisingly, living in a traditional community, such as a home that you own or rent or an apartment, is lowest in the 85 and older. The light-colored bar is community housing with services, and this is an important place where nutrition services may or may not be provided. For example, in HUD low-income housing, they may not have meal services, but other types of private pay, such as assisted living or personal care home, would have meal services. And long-term care facilities by law are required to have nutritious food. Of course, there's other issues there, but availability of food will vary with the health status of the individual and their living situation. Well, where do older people receive long-term care? We used to just think about long-term care in terms of nursing homes, but we now also have residential care communities, example, personal care or assisted living. We have adult day service, a very important service, not as large in number, but very meaningful to families that are caregivers. And home health agencies are a very important place where the right kind of food and nutrition services can really make a difference in helping people stay at home. And what we're seeing now is social service and medical service agencies trying to work together closely around the issue of food. We won't talk about hospice today, but there certainly are important nutrition and hydration concerns at the very, very end of life. I used to think biomarkers of healthy aging only involved things in your blood, but we're going to see it's so much more complicated and holistic than that. It can involve what diseases you have, when you got them, the progression, their severity, your physiological function, your function of your endocrine immune, inflammatory responses, your genetics. But another way of thinking about it is our physical and mental capability, our health care, our transitions of care, how do we maintain independence, how do we avoid nursing home admissions, food and nutrition services are a part of that, and prevent hospital readmissions. So the next few slides will give you some examples of how researchers are searching for biomarkers of healthy aging. So I have 5 different studies that have very different ways of going about this. So the first is cellular and animal studies. The next is the MARC-AGE study, where they're enrolling many people and watching them over time for their biological markers of aging. The longevity phenotype, which is the healthy aging index. Mortality predictors, which is systematic reviews of cohort studies. And finally, function, that is a geriatric perspective. Let's first look at the cellular studies, and I redrew this figure from Dato, and how to read the figure is to start at the bottom, and that represents middle age, when we're getting to be at risk for age-related diseases. And these researchers conceptualized the nutrition milieu at that time as high in calories, high in protein, with micronutrient deficiencies. So if we want to reach the top of this pyramid, we need to get our vitamins and minerals balanced, reduce our protein intake, and practice dietary restriction. And that'll get us to healthy aging and longevity. So about the time I found this paper and was thinking about this, a colleague from another university called and said, oh, my studies in mice, I'm finding that there's some real benefits of low-protein diets for aging. I just need to add a few amino acids, and they have better bone health and muscle function. Let's think about how we can translate these studies to aging. I said, oh, wow, that's very hard to translate these kinds of studies to humans. We need to proceed with caution. I was so cautious I even got a veterinarian to help me think this through of translating studies from animals to people. First of all, the human requirement for protein could be higher than current recommendations. And I don't know if my IRB would even let me think about feeding anyone a low-protein diet. And we also have a high prevalence of food insecurity in the very populations with the highest chronic disease prevalence, incidence, and severity. So there's a lot to think about. Certainly cellular and animal studies are absolutely critical for us to understand the biological, mechanistic basis for aging in general and how nutrition and other interventions can make a difference. But it takes a lot of thinking to figure this out. The second study I want to share with you is the MARC-AGE study, and they are enrolling over 3,000 people. One group is from 35 to 74 because we can't tell what's unique about older people unless we can compare them to other age groups. They're also enrolling long-lived families who may be enriched for environmental or genetic markers of longevity. And then some of the individuals will participate in longitudinal studies, which is really critical for us looking at how the aging process unfolds over time and what's involved in successfully aging. The first 7 or 6 different groups, they organize themselves in groups, are looking at things you'd expect, how to recruit the right kind of people to answer your research questions, DNA, protein, immunology, clinical chemistry, oxidative markers. The 7th is looking back into the cellular and animal data to see what's coming out of there that could really inform us in the kinds of markers we should use for this sort of study. And they end up with a 10th group that's looking at how do you manage all this data, and then what are the ethical issues in safeguarding the data and informing participants about issues as they arrive. So this would be a very exciting study to follow as data become available. Another approach is to identify a longevity phenotype, and this was done by developing the Healthy Aging Index. And it's very different from the previous study, which is collecting massive amounts of data now. This is looking back at data that they already had, and they found 5 measures they think are really critical. And they wanted to identify a subset of variables that are also heritable and predict mortality. And this comes from the CHS study, which is an ongoing community-based study of CVD risk in 6,000 participants who are 65 and older. And the 5 measures that they identified were systolic blood pressure, lung function, creatinine, fasting glucose, and a cognitive measure known as the mini mental status examination. And each of these domains is scored, and the scores are summed. And one of the analyses that they did was to look at those in the worst category versus the best category of the HAI score, and the mortality hazard ratio was 2.6, meaning over 2.5 times more hazard of dying. So very significant. They also looked at the heritability overall, and that was about 0.3, just reminding us, of course they did this on purpose, they looked for genetic related markers, but it's about 0.3. So we have to be mindful that as we're searching for healthy aging biomarkers, many of them will be heritable. How does our nutrition fit in that? Is it gene environment interactions with nutrition being environment? It's complicated, but quite interesting. I think this is the 4th study. Now we have so many studies that can predict mortality over time. Researchers are doing systematic reviews of these cohort studies. And this group of researchers found 23 studies. They focused exclusively on blood biomarkers. They found about 50 in their various literature they reviewed, and 20 they thought had potential. And one was a biomarker of vitamin D. And only a few underwent meta-analyses because there's not enough studies of some biomarkers to do a full meta-analysis. And the 3 listed below were associated with all-cause mortality. C-reactive protein, which is an inflammatory marker, and interestingly, this one was independent of the follow-up period, meaning that even with a short-term follow-up period, there was still a relationship with mortality. The white cell count, a marker of immune function, and then NT-proBNP, which B is for brain, even though it has brain in the title, it is a biomarker that's also very highly related to many indices related to heart function and heart failure, so a CVD risk factor. So very, very interesting set of biomarkers here, and there's quite a bit of data in this paper. It's very interesting to look and see what kinds of other markers are associated with other disease, but we've got 3 strong contenders right here. The 5th and last is from a function and geriatric perspective. And this work is coming from John Mather's group in Newcastle, and they responded to a request from the Medical Research Council and reviewed literature in several domains. They have an extensive process of expert feedback and workshops, and the MRC Population Health Sciences group is overseeing their work. And so they are taking a very much public health approach. And they have a panel of biomarkers of healthy aging, and they've organized them into 5 groups. And the biomarkers are a physiological function group and an endocrine function group. And these will be very familiar, the physiological markers, cardiovascular, lung, glucose, body composition. We're going to hear from researchers today about many of these domains. And the endocrine function, the HPA axis, sex hormones, and growth hormones. Those are our first 2 groups. And then the next 3 groups include physical capability, so important for older adults. Geriatricians are very on this. Need strength to do your daily activities, to lift things, get up out of a chair, walk around. Balance, extremely important. Poor balance is linked to falls. 1 out of 3 older people fall every year. Fall is the leading cause of bone fractures, of traumatic brain injury. So very, very critical we address falls by improving people's balance. Locomotion related to people walking. So there's very good time tests for gait speed, up and go, being able to get out of a chair. Extremely important area for healthy aging biomarkers. Physical activity people, kinesiology folks got the corner on this market, but there are some studies coming out now. For example, Connie Bale's group is showing some positive outcomes of high quality dietary protein interventions and some aspects of function in the physical capability domain. Cognition, very important, so our psychologists can do appropriate tests for memory, processing speed, and executive function. Obviously, we've got to have good cognitive function to remain independently living in our home and being able to do our instrumental activities of daily living, our shopping, our balancing our checkbook, talking on the phone, which is a lot harder than it used to be with cell phones, using our iPad and our smartphone. All very important. And immune function through the inflammatory markers, IL-6 and TNF-alpha. So a very good panel that this team has come up with. So, where does nutrition fit in? Clearly, it's in the biological pathways of aging, especially through an age-related disease, especially through disease prevention and treatment, including obesity. We need to be thinking about, are we meeting the current dietary recommendations, our DRIs, our dietary guidelines, and keeping up with any new developments that are coming related to dietary requirements. So, for example, protein. We'll talk about that in just a minute. We need to be mindful of food insecurity in older people. We can come up with the most fabulous evidence-based recommendations of how nutrition can keep older people healthy, but if they simply don't have access to the food and don't have the food, it's not going to be possible for all people to realize these gains. So national data from USDA, published by USDA, over 8% of older people nationally are food insecure, over 50% in vulnerable subgroups of older people, such as people on the home delivered meals waiting list in Georgia, and that work was done by Jung-Sung Lee in Georgia. We need to think about nutrition interventions for costly biomarkers or costly outcomes. Sometimes we don't think like health economists, or we don't think like insurance agents or government payers. We need to start thinking about that. Where can nutrition really make a difference in the national conversation on controlling healthcare costs? So improving care transitions, decreasing hospital readmissions, and I just learned this from a new faculty member. He's a retired chief information officer for maybe 20 hospitals in North Carolina, where that was his job, make this hospital stay afloat. And he shared with us the other day that we have these markers that hospitals need to meet. Other care organizations are called quality care measures. I picked out just a few that are nutrition related, such as depression, hemoglobin A1C, blood pressure, heart failure, and CVD. These are costly to hospitals when these are not controlled properly. Can save them money when they're controlled properly. There's penalties if these aren't done right. So think about, how can nutrition interventions make a difference in these healthy aging markers, also known as Affordable Care Organization quality care measures. Let's look at the Healthy Eating Index. When this is 100% for any of these food or nutrient measures, that means the population and the age group is meeting the recommendations on average. But we can see dairy is low, so that's a particular concern for bone health and getting high quality protein. Our fatty acids are low. We're going to hear more about that. And our sodium is low. Low means we're eating too much in this context. So we have some work to do there. We also need to make sure we get our sodium recommendations right. So we need research in that area. Now, I circled total protein in red because it looks like, wow, we're meeting that. Older people are meeting that. But there is important research being done that maybe our protein requirements are higher than our official recommendations. So we just need to monitor that and make sure these important indexes like the Healthy Eating Index keeps up with the latest research. It'll take a while to sort that out, but just think about that. Obesity, clearly a problem in older people, especially in this young age group, are at the highest risk for obesity. And also, people over 60 is the only subgroup of the age subgroup of the population where obesity prevalence is still increasing between 2003 and 2011, I believe it is. Also, obesity is known to accelerate aging because it leads to poor mobility, diabetes, many other chronic diseases, and people need to take more medications. We now have good evidence that obesity and diabetes are risk factors for premature admission to nursing homes. So, again, think about this in terms of economics. It's very costly to have a disease that could be improved or prevented, at least in part, or at least partially managed through lifestyle factors that involve nutrition. And think how much quality of life people would, improvements in their quality of life they would experience, and healthcare costs if people did not need to go into long-term care. So we're going to hear more about that. Nutrition transitions just mean, most people, people want to be independent living, but things happen. They end up over here on the right, in acute care or long-term care. Then they get discharged. Hopefully they can intersect with their home and community-based services that are in every community and get Meals on Wheels or nutrition counseling to help prevent a readmission to the hospital and get them back living independently. So we're having a lot of conversations between the social service system, which is here, HCBS, and the medical system, how we can work together for the benefit of older people. So, in summary, we're still learning about nutrition and development throughout the lifespan. We've got exciting new areas of concern, the microbiota. But how can our food and nutrient recommendations address food insecurity? Too many seniors lack nutritious food. That's not right in a country like ours. Nutrition's role in maintaining functional markers. If you really want to get payers, aging service providers, geriatricians, gerontologists excited about nutrition, you've got to think about improve nutrition's role in all these factors listed here. And think about nutrition interventions that can help with transitions of care, decreasing readmissions to hospital and other costly services, and how we can improve affordable care organizations' quality care measures. Thank you, and I look forward to talking with you and discussing these and all the issues you're going to bring up. Thank you for your attention.